Jean Lemoine, and I'm a resident in hematology in Paris. And I will present during the 64th ISH meeting the result of the analysis of the non-relapse mortality after the treatment with CD19 CAR T-Cell for relapse or refractory diffuse large B-Cell lymphoma that was conducted by the LYSA and by the DESCAR-T Registry. So when you try to improve the outcome of patients after CAR T-cell treatment, you may try to improve the efficacy of CAR T-cell therapy, but you can also try to reduce the non-relapse mortality associated with this treatment. And that's why our study will focus on non-relapse mortality description. For this study, we analyzed 957 consecutive patients registered in the DESCAR-T Registry between July 2018 and April 2022 that were infused either by tisagenlecleucel or by axicabtagene-ciloleucel. On our global population of 957 patients, we describe 48 deaths that were not due to disease progression and that define our overall non-relapse mortality population. Among these 48 deaths, we describe 9 deaths occurring before day 28 post-CAR infusion and 39 of deaths occurring beyond day 28 post-CAR infusion. So the overall result are a global NRM rate of 5%, with about 80% of this NRM occurring beyond day 28. This low non-relapse mortality rate associated with CD19 CAR T-cell treatment for relapse or refractory diffuse large B-cell lymphoma were aligned with data coming from both pivotal trials, but also with real-world experience cohorts. Concerning the causes of death in this registry, the early deaths occurring before day 28 were 4 non-COVID infection and 5 cytokine release syndrome. Concerning the 39 deaths occurring beyond day 28 post-infusion, we had 10 non-COVID infection, but also 13 COVID infection, 2 ICANS, and other causes of death. Overall, infections were responsible for 56% of the death reported, with half infectious, half fatal infection due to COVID and half non-COVID associated. So then we tried to identify risk factors associated with early NRM. And in a univariate analysis, we found that the age of the patient, the body mass index, but also the ECOG-PS of 2 or more, a low hemoglobin level, elevated LDH, elevated ferritin were associated with a risk of early non-relapse mortality. Interestingly, the type of CAR T-cell, either tisagenlecleucel or axicabtagene-ciloleucel, was not associated with early non-relapse mortality. We performed the same analysis on overall non-relapse mortality on a univariate way, and we found that risk factors associated with overall non-relapse mortality were the age of the patient, the diabetes status, but also variables at lymphodepletion as ECOG-PS of 2 or more, low hemoglobin level, low platelet counts, higher CRP, but also higher ferritin. Here also, the type of the CAR T-cell, either tisagenlecleucel or axicabtagene-ciloleucel, was not associated with a risk of overall non-relapse mortality. With this different data, we developed an NRM CAR predictive score, including 4 variables that were an age of more than 65-year-old, the diabetes, an ECOG PS of 2 or more at lymphodepletion, and an elevated ferritin at lymphodepletion. This score defines 2 groups of patients, a group of low risk, that is 0 or 1, and a high risk, or 2 to 4. And these 2 groups are associated with different risk of overall NRM. However, in both populations, the risk for non-relapse mortality stay low. As a conclusion, this study allows us to better describe the outcome of patients treated with CD19 CAR T-cell for relapse or refractory diffuse large B-cell lymphoma. We can find that non-relapse mortality is a really rare event with this treatment, and that it usually occurred beyond day 28 for about 80% of the cases. In our cohort, the most cause of NRM is infectious disease, with half non-COVID and half COVID infection. Then we think that developing score to predict the risk of NRM may help guide patient selection and management to improve the outcome of this patient after treatment with CAR T-cell.